And welcome to anyone who has just joined us. Just to let you know, we will be kicking off the webinar very shortly at about 2 minutes past 10. Okay, we're going to get going. Thank you and welcome, welcome everyone. Thanks for joining us today as LaingBuisson hosts its first webinar under the new Labour government. I imagine some people will still be kind of trickling in, but conscious of time, I'd like us to get going so we can get through as many questions as we can. Our focus today will be on examining what the new landscape means for the private sector. And I'm delighted to be joined by our truly expert panel who will be sharing their views on what the changing government may mean for the independent sector and how providers and others in the sector may seek to navigate these changes. I'll introduce our panel momentarily, but first just the usual housekeeping. For anyone who is joining us, just to be aware, we're operating under the Chatham House rules. This means that whilst people can, of course, report back on the themes of the event, please do not attribute any comments to specific participants. However, I am pleased to say that all of our panelists have indicated that if there are any specific things that you'd like to directly quote from them, please feel to reach out to them after the webinar, and LaingBuisson can help facilitate the introduction if that's necessary. The webinar is scheduled for an hour. We will kick off with some specific questions for our panelists, but I also want to make sure that we reflect the key areas for yourselves. And I know that some people have submitted questions in advance, but some may occur to you based on what our panelists say today. So we do have a Q&A function available. So if there are questions that you want to put into the chat or any comments, please do so. The level of interest has been such that I'm afraid we're probably unlikely to get through all of the questions, but we will try to pick up as many as we can. And so without further ado, I'd like to introduce our panel. I'm extremely pleased to say that we've been joined today by Carnall Farrar, Chief Executive and co-founder of CF, David Hare, the Chief Executive at the Independent Providers Healthcare Network, or the Independent Healthcare Providers Network, sorry, David, and Justin Ashby, Chief Executive of Spire Healthcare Group. Now, I'll ask each of them to give a brief introduction to themselves when coming to them with a specific question, but I can say that between them, there is a vast array of experience covering both the independent sector and the way that the NHS runs its own services, including its relationship with alternative providers. I feel that my role today is very much just to set the scene and ask for questions and leave our panelists as much time and space as possible to provide their viewpoint. So where are we? I doubt anyone joining today is unaware of the basic facts, but I will just recount some of them just to set the scene. Last week, the general election caused a complete shift in the current political landscape. After 14 of what were often turbulent years, the Conservative Party is no longer in power, and the UK can look forward presumably for the next 5 years, to a Labour government under the direction of Keir Starmer. I think it's fair to say that it's a shift that everyone has been expecting, but perhaps the scale of the Labour victory may have caught some by surprise. A majority of over 170, which was of course aided in part by a complete collapse in the Conservative vote, has given Labour relative freedom in pursuing its manifesto pledges and setting the agenda it wishes to for the next 5 years. Now, during the campaign, Labour came under some pressure from the left for being too unambitious in its proposals, and whilst the leadership has reinforced the slow and steady approach since its relatively short time in office, the large majority they have received may well lead to continued pressure from those on the left to push a more radical policy agenda. This may have particular resonance in the relationship between the NHS and the independent sector, which has in the past been a flashpoint for some of the sort of pressure on the role of the private sector in public services. And I would be interested to sort of our panelists to perhaps reflect on that relationship as part of their answers, as it fundamentally impacts on the everyday working relationship between the NHS and the way that private providers can support the sector. Wes Streeting has been, as expected, appointed Secretary of State and has been positive in opposition about the role of the independent sector, certainly in delivering NHS-funded services. However, what this means in reality will be examined closely in the years ahead. The manifesto itself points to 40,000 more appointments every week, 2 million per year effectively, doubling the number of cancer scanners, a dentistry rescue plan, 8,500 additional mental health staff, and the return of a family doctor. A lot of laudable ambitions, but of course they are under a tight fiscal envelope. And the Financial Times have already reported that it's likely that the government intends to take a financial review of the NHS's finance and performance activity, potentially an approach that may give Labour cover if they discover they can't be as ambitious as they plan, or alternatively, it could be used by the DHSC to place greater control over local decision-making. We'll have to await the outcomes of those of that financial review. However, maybe it's too early to tell, but again, I asked the panel to draw on their experiences about how Labour may look to resolve the challenges they face on NHS performance. And I think this acts as a nice segue for introducing the first of our panelists. Hannah, CF has undertaken extensive work with the NHS across the country over the years, and I believe that you have some slides that can illustrate the scale of the challenge facing the government to get the NHS back on track. So thank you for joining us today. And perhaps before going into the challenge, perhaps could I ask you briefly to introduce yourself and CF to those who may not know you.
Thanks so much, Tim. It's great to be here with you all today talking about these really important issues. As Tim has said, I'm the CEO of CF, and we're the largest consultancy in the UK dedicated to the health sector. We work across all aspects of it, public, private. We work with government, we work with investors, we work with providers, payers, life sciences, and the wider supply chain. And given the materiality of the NHS to the UK health sector, it is an area we are expert in and are passionate about. And our passion extends to our data. We have more access to health data in the UK than any other firm, and we use it a lot in our work. And so in terms of today's session, Tim's asked us to use some of it to set a bit of a scene to give you some insight. And obviously their manifesto is broad. And so we've just gone after one topic. Otherwise we'll be here for the full hour. And that is the waiting list. Wes this week said it was a kind of totemic issue for them to address it within the first term. And so we have a couple of slides to kind of bring that into context for you and help you understand the size of the challenge. So I think about the waiting list in two ways. The first is, what does the government need to do to get the NHS to sustainably deliver 18 weeks? And they want to do that over the course of this term. And then secondly, what do they need to do to address the excess number of people who are on the waiting list, which was exacerbated by COVID? But the reason why I start with 18 weeks and this chart is it was a very long time ago that the NHS sustainably hit 18 weeks as a standard. So the pink is telling you people who are leaving the waiting list each year or in that month in the year, and the blue is telling you when people are joining. So to get stability in the waiting list, for it not to be growing, those two lines need to be together. And you can see from October 15 through to today, at no point does that happen other than when services were shut temporarily during COVID. So that's a bit of a scene set to there's an 18-week problem. We haven't delivered it for a long time. We need to get there as well as dealing with the backlog. So the next one is a bit of a wall of numbers, but it's just to give you a sense that you have to think about the waiting list by specialty. And because the data is better, I'm only looking at physical health specialties here. The same kind of concept and problem applies to the mental health and learning disability weights as well. And in fact, some of those weights are longer. So what you're seeing here is every kind of major specialty, what your optimum size of that waiting list would be for you to deliver 18 weeks. That's your BAU. And therefore, what the actual size is currently, that's your total. And then what's over and above that. So that's this one-off, non-recurrent issue that needs to also be addressed over the course of this Parliament. And so what is that as a percentage of the BAU level of activity gives you a sense for how much more activity each year is required if you're going to address that. And those in the pink, our version of a red, are showing you that it is well over 25% in those specialties. Additional activity is needed every year. On the blue, admitted; on the pink, non-admitted, so your outpatient-based requirement. So it varies significantly by specialty. It also varies geographically. And so I've just two maps which kind of use the NHS's regions. The first one shows you, well, what is that gulf in delivering the 18-week standard? How much have they got to bridge to get that? And you can see a range of percentages, both in the admitted and the non-admitted pathway. And that is, to me, permanent increases in capacity are needed there in order to bridge the gap. And you've got to remember there's a growth rate each year in some specialties as well, although some specialties are on the decline. And then the next one shows you, in terms of this excess requirement, how does that change geographically? And again, you can see, depending on where you are in the country, there's more of a bridge to gap. And this is not where I would put in more permanent capacity. It is a one-off requirement. So it's where you have to use capacity kind of flexibly, creatively to do it, and workforce as well, as opposed to putting in more permanent cost because it's only a temporary demand. So hopefully that gives you a little bit of a flavour of the challenge that they've got in front of them in order to bridge this performance gap over the next term.
Fantastic, Hannah. Thank you so much for that. And I think it was really useful in showing both the scale of the problem at the national level, but also critically that that problem is very different from a patient experience perspective, depending on where you are in the country. So perhaps as a kind of follow-up to that, and to pose a question for you, I mean, one of the things that jumps out at me is that if Labour are going to be successful in introducing this sort of very sort of specific 40,000 additional scans, ops and appointments, now, its success ultimately doesn't rest on NHS decision makers, but it's going to rest on integrated care boards and chief execs of NHS acute trusts and the people delivering it at the local level. And I think that regional graphic really highlighted that. So from your perspective and from your experience, what do you think in reality has changed for the NHS as a result of the election, as a result of Labour having a 179-seat majority? And what do you think needs to change in order to make those manifesto pledges anything approaching a reality?
Okay, so maybe I'll start by just putting the 40,000 into perspective. So they want to do 40,000 more a week. And remember, I'm looking at people on a waiting list. Well, in fact, I'm not, because there's some people who are on it more than once, which is one thing I think should change. Think about the person, not the clock start. It's a slightly technocratic way of thinking about it. But for anybody on that waiting list, multiple things need to happen in order for their care to come to a conclusion. And the kind of number of diagnostic episodes that happen nationally each year is a very hard number to get at. But what they've said is it's 40,000 diagnostics or outpatients or procedures a week. So say that's roughly 2 million a year. If I ignore the diagnostics and I just think about outpatients and procedures, we've got 24.5 million of those happening each year at the moment. to not hit the 18-week standard. And so 2 million more isn't going to bridge the type of issue that I've said. It's a really great start. It's a big, it's a stretch for the service to do it. It's a productivity ask for them. And I think the NHS will be able to do that kind of first target, but it doesn't solve the problem. And the more material thing is, well, how actually do you sustainably hit 18 weeks? And what is the role in the private sector to supporting a kind of more plural provision and having that sustainably? One of the issues that the NHS is struggling with is the fact that it tries to co-locate emergency and planned care together so much. And that's what kind of crowds out the planned care requirement. And I think the private sector has all sorts of different opportunities to help with that. And then the digital and tech agenda is the game-changing kind of revolution that can happen across all different aspects of the government's manifesto, but it applies to this issue as well.
Fantastic, really great perspective, and I think naturally leads us perhaps to David. The independent healthcare providers network is the voice of the sector. It reflects a broad sweep of providers operating in the independent sector, and I think a lot of people will be looking at your organisation for a steer on the mood from providers as a result of the Labour victory. For the benefit of those on the call who may not know IHPN, could I ask you to introduce yourself and the organisation? And before moving on from that, perhaps lead the following with you to provide a perspective on. So firstly, for those less familiar with the dynamics of the sector, could you give us a sense perhaps of how the independent sector as a whole is likely to be feeling about the news that Labour are coming into power with a 170 seat plus majority? And then perhaps as a follow-up, as Chief Executive of IHPN, what would you most want Wes Streeting and the Labour Party as a whole to understand about the independent healthcare sector? Hopefully not too big a question for you there to get going with.
I'll try and condense my answer into some brief remarks. Great to join you, Tim, and thanks for the invitation. So for those that don't know me, I'm David Hare, the Chief Executive of the Independent Healthcare Providers Network, the trade association for the UK independent healthcare sector. Broad church of just over 100 members covering acute hospitals, diagnostic providers, primary community care, etc. are a sort of real rich array of operators. So reaction to the news of a Labour majority, I was quite surprised by the timing of the election, but probably based on the polls, not hugely surprised by the outcome. As a non-sort of party political organisation, we were absolutely ready to work with whichever form of government emerged after the campaign. But clearly it is a Labour government and one with a very big majority. As you'd expect, we've been talking to all political parties, including Labour, and I think like the rest of the business community actually have been very pleased in recent years with kind of Labour's willingness to work collaboratively with the private sector. This is my fourth election in this job, and that hasn't always been the case, perhaps from the Labour benches, but that's certainly very different this time around. And I think it is noteworthy, Tim, that we've had a campaign where there's been a cross-party consensus on the important role that the private sector has got to play in recovering NHS services. There has, for many, many years, sort of been a kind of limiting factor to the government of the day, based on sort of accusations that any involvement of the private sector equates to privatisation of the health service. That doesn't really stand scrutiny and is something we push back on. I think probably has made it more challenging for NHS performance to improve over recent years. So it's really pleasing to see that. I think, again, the general view, certainly my view, but I think speaking to providers is, the private sector, in an NHS context is neither saviour nor villain. There's an important contribution that can be made. I often hear it's not a silver bullet. No, it isn't a silver bullet. There is a lot that can be done to improve overall service provision, and we are making that case and have been making that case very clearly to government. I think both a big majority and a probable, as you said, Tim, 5 years in power provide the new government with an opportunity to develop a medium to long-term plan. One of the frustrations with I think most private providers, wherever they are in the market, is that short-termism just doesn't equate to a long-term investment cycle. And if the government of the day, it means what it says, and I genuinely believe that it does, that it wants to work with the private sector, we need some long-term planning. And we saw this morning announcements of sort of 10-year plans in the offing and so on. I think that's clearly really welcome. I think part of recent political developments has really been the government of the day opening the door to talking about the successes of when they were last in office. And I think, again, that helps because the private sector was a big part of helping to get performance back on track in the 2000s. Can definitely be again. If I look at the last sort of 18 months, 2 years of the Conservative government, actually what they were pushing, choice, payment by results, role of the private sector, etc., capital investment in diagnostic services, are all things which, in the 2000s were deployed. So there's quite a nice sort of segue into a new government in policy terms to take that on and kind of drive that forward. And I think, overall the sector is really, really keen to play its part. We talk about sort of the 4 Cs, adding capacity, capital investment, contribution to productivity and efficiency, and community provision as well. And clearly West Streeting talked about investing in community and primary care, which is really welcome. And then sort of final observation in terms of how people are generally feeling. There was obviously a bit of debate around the private market during the election. Pleasing to see, I think, government figures sort of talking about the respect that they have for people that choose to do that. I think private care will be inevitably a feature of healthcare for a long time to come. So that's sort of the how are people feeling bit of the question, Tim. What are we sort of saying to new government? It's obviously coming together as we speak. So 5 things quickly there, and then I'll stop. So first things first, basic entry point is quality and safety. We take that really, really seriously. We have a mantra in the industry that we don't compete on safety. I think in recent years, a huge amount of work has gone in to improve overall safety. There's still further work to do, but it's great that I think now 94% of IHPN members are rated good or outstanding by the CQC. That's really positive. Second message, we're a broad church and it isn't static. The sector can do lots of different things. And if the right conditions are created, new entrants can emerge and existing players can expand and innovate, and those conditions need to be the right ones. It's value for money where the tariff applies. The sector is paid the NHS tariff price, and that can really help to sort of drive activity levels up. The sector can mobilise rapidly and can turn new services around very, very quickly. But within all of that, we need some stability and a long-term framework within which to operate, and crucially, a way in. And clearly in recent years, the focus has been on integration perhaps rather than competition. But if a new government is serious about opening the door to innovation from the private sector, it will need to ensure that there's confidence that those services can enter the market and won't be blocked by the NHS. I'll pause there.
David, thank you so much, and really great to kind of provide a kind of view across kind of a sector, kind of an understanding with it. It is a broad church of different types of provider who operate in the space. And that kind of leads us to being able to introduce one of the kind of the chief sector, one of the leading hospital groups in the country. Justin Ash, thank you so much for joining us today, Chief Executive of Spire Healthcare Group. Now, Spire is a multi-specialty provider that offers services across multiple areas to both the NHS and private pay markets. For the benefits of those on the call, perhaps I could ask you in a moment to provide a brief overview of the company for those who don't know it so well. And perhaps first off, if I could ask you to reflect on the following. You've heard Hannah talk about NHS dynamics, and David has reflected kind of on the ask of the government. But for you, as somebody kind of running a hospital group catering to both markets, I'm kind of interested in what the reality looks like for you. When you came into your office on Monday this week, where did the change of government actually rank on your list of priorities? Is it top of the list, or is it just another thing in the in tray? And I will have a follow-up to that, but I will let you go with that one to begin with.
Well, thank you for the introduction. Hello, everybody. As Tim said, I'm Justin Ash. I'm Chief Executive of Spire Healthcare. I just realised I have 20 years of being the Chief Executive in healthcare, originally in pharmacy, running Lloyd's Pharmacy, then Oasis Dental Care and Dentistry, and now in hospitals. So I've seen quite a few changes of government. And I think it is first of all, appropriate to congratulate the government on their decisive election win and Wes Streeting for his appointment. And I think it is important to note the size of the majority, because over that period, it is my observation that you do get the most radical and effective change when governments have strong majorities and clear mandates. They'll also be thinking that in some places it was quite a narrow majority in some seats. So I think generally we should expect change and decisiveness from the government. That's what I've seen in my last 20 years. So Spire Healthcare, as many people may know, we're the largest independent healthcare provider in the UK. Our core is hospitals. We have 38 hospitals outside of London. A lot of our work is, of course, hips and knees, but we also have complex care, cardiac care, cancer care. So we're a broad range hospital provider. We also now have the largest community talking therapies provider to the NHS and a large community physiotherapy activity. So the simple answer to your question is on Monday morning when we had our executive meeting, yes, we were discussing the change of government, and we do think it is important. So let me just try and put that in context. So first of all, about 70+% of what we do is treating private patients, either self-paying or largely insured. Those patients make a vital contribution to waiting lists because they aren't walking into an NHS GP. We have private GPs. They're not waiting for diagnosis, and they're not waiting for treatment, and they may be paying for it, or their employer may be paying for it. But we treat 1 million patients. Of those, 800,000 roughly are private. And I think, although that's not today's topic, remember that is also contributing to the waiting list not being higher. Nonetheless, we treat about roughly 200,000 NHS patients a year. And I do think the first thing, I think Hannah pointed out something really important, the distinction between building waiting lists and business as usual. So the contribution of Spire and the independent sector to business as usual is really critical. It's been noted in the FT today, which did get some facts wrong, which I'll point out later, but the core load of orthopedics and other surgery is provided by the independent sector. So the contribution is significant, and that continued contribution is vital to getting waiting lists down. Now, we make thousands of appointments available to the NHS every month on what's called the electronic referral system. And we are debating, should we make more available? So first of all, thousands of those are not taken up by the NHS. And doing a rough calculation, this is the chief exec calculation, not an analyst one, I reckon that those appointments which aren't taken up equate to about 2 weeks worth of those 40,000 appointments a week. So that's Spire. That's 2 weeks of the 52 weeks solved simply by using the slots we already make available. Now, they don't go to waste because we find ways to fill them. And some of them, obviously a lot are filled by the NHS, but it's remarkable, isn't it, to think there's 2 weeks worth of 40,000 appointments just going wasted. And I'm pretty certain that the rest of the independent sector in NHS care, we're about 10%, will have similar statistics. So the independent sector is not the solution. However, we are a material part of it. So as a team, of course, we will lean in to support the government. They have a decisive majority. We are part of the public service as well as being a public company. We will continue to make those slots available, and to a government with determination, I'm sure we'd make more available. Now, the caveat is we have seen full storms before. So if you go over those 20 years, you see there's a lot of talk about using the independent sector. There is nothing more difficult as a provider than making slots available and not filling them. That's inefficient. We need to be efficient for the sake of patients. So we are actively discussing how do we help more. What we're looking forward to, first of all, I think, is how do we fill the slots that we already make available. And I would also add, for me, radical means thinking about patients first. 68% of patients fully support the idea that the independent sector should help reducing waiting lists. That's research which we've done. 74%, by the way, would go private if they felt that a loved one needed treatment and couldn't get it on the NHS. So that's fully accepted. patients support a mandate to use the independent sector. So a radical approach is put patients at the front of the agenda of solving the waiting list problem.
But no, that's absolutely fantastic. Thanks, Justin. And I think based on your response, I'm going to kind of seed my follow-up and in fact go to one in the chat instead, because I think it directly follows on from what you said. So Olivia Reed in the chat sort of asked yourself, Justin, but I might also come to Hannah for your perspective on this as well, having worked with the NHS a lot. But Justin, perhaps you first. Why do you think the NHS, for you as the as chief executive Spire, what is your perspective on why the NHS doesn't seem to be taking up the appointments which are being on offer? And then Hannah, if I come to you afterwards, perhaps to give a perspective, perhaps on the NHS as to what are the blockages or barriers in taking these up. But Justin, to you first, if that's okay.
So I don't really know, because I don't run the NHS, and it's not for me to opine on why they do things. Talking to commissioners, I suspect that financial constraints and the way that they are incentivized is what drives it. I don't come across much, if any, philosophical hostility. Maybe it exists and I just don't speak to those people. But the people we speak to basically cite the fact that the way the current incentives work, it's difficult for them to justify spending money. If you go right back to 2017 and before, there were penalties for missing waiting list targets. They were introduced by Labour. There was a lot of commissioning of the independent sector because it's an effective solution. I suspect it is financial rather than philosophical. There is some restriction of choice. Choice is key to this. Those slots were made available on the electronic referral system, and we work with GPs to point out to them how to use it. Not saying use Spire, just pointing out to them, if you go on there and look, you'll see how long the waiting lists are. In a number of areas, that's been turned off. It's against the previous government's policy. We'll see what the new government has to say, for whatever reason. But I suspect, as with most things, it's financial. But I don't really know, because I'm not at the top table in that regard. Hannah may have more of an insight.
Right. Hannah, well, you've heard from Justin. How about yourself from the perhaps from the NHS side? And David, I might actually come to you, because from other parts of the sector, you might be hearing different messages. But Hannah, yourself first.
I guess one of the beauties of what I do is I get a bit of a helicopter view. So and I work with all sorts of different organisations, so you get to see all different perspectives. And Justin made such a fabulous point about the waste that happens with his own organisation. And I guess I'd just start by saying that would be true of an NHS provider as well. So they have slots which are unused or underused every week. And there's a different question about workforce, which maybe we'll come to because it merits a longer question. But I guess I would see that in any provider not fully utilising available capacity is quite a rare thing. So I would say, why does that happen everywhere, including with Justin's available capacity? Partly, I think there's like an administrative process, and Justin said, put the patient first, and the way people are communicated with about how to follow their own pathway of care and make it easy for them, that there is a fault line simply there. And the amount of notice that people are given, the way that they're spoken to about it, or people still get written to with letters in a kind of slow, old-fashioned way. That is a fault line for me in terms of seamless access to care in a way that's accessible and understandable to the individual, and also being ready and prepared for the appointment that's available to them. And then I do agree with Justin's point that there is an inherent tension, and maybe it's kind of more fundamental to how do you fix this in a more radical way than just underutilization of existing capacity, is like how the money works and people feeling fairly compensated for their contribution to it, whether they be a public or a private provider, has to be part of what needs to be worked through to solve this problem over the longer term.
Great, fantastic. And I think we'll come back to the patient question specifically, I think. But David, over to you for sort of other views from the sector, what you may be hearing from other providers.
Yeah, just very quickly. I mean, I think on Justin's point around unused slots, that is absolutely the case across the sector. We're just trying to finalise the numbers now, but there are tens and tens of thousands of slots every month that get pulled by an independent sector provider within a sort of week, 10 days of that slot being available. As Justin says, that often gets redeployed, but there is a huge opportunity to make better use of that. And one thing that we'll be looking at really closely for is the way the funding flows for that extra 40,000 appointments a week, because if it is simply given straight to NHS trusts to do, I think you'll get less bang for buck than if you put it through the tariff system and include the independent sector in that, because they could very quickly scale up based on that availability. I think sort of an additional point around the importance of choice. We know that a big part of the increase in independent sector activity post-pandemic has been in ophthalmology. It's the only specialty now where the median waiting time is less than it was in 2019, which is clearly great news for patients. And that's partly driven by the fact there's a fairly free-flowing patient choice route out of high street optoms, and too often for other specialties, we find with referral management centres and varying other things that it's really sticky to get a patient from the point of referral through to an independent sector provider who we know can treat the patients reasonably quickly. And I see there's a question in the chat from Nadine about transferring patients. It is so much harder to transfer patients off the back of trust lists, particularly after they've had an initial outpatient appointment, than it is to make sure choice is genuinely being offered at the point of referral, and that has been allowed to degrade over the course of the last 10 years. So very hopeful that Labour will make sure that's fully reinvigorated.
Fantastic, thanks, David. And so, in keeping it on the subject of patients, because ultimately this is healthcare. It's about individuals. It's about people who have a need which they would like, understandably, to be resolved in a timely manner. Going up to kind of perhaps the first question we had, and I think it's a very pertinent one. Patient choice is conspicuous by its absence in the manifesto, notwithstanding that it was a Labour policy originally. What is the prognosis for patient choice? Or perhaps maybe reframing that slightly, does what we understand patient choice to mean perhaps need to change in the future kind of healthcare landscape? I don't know if anyone wants to sort of pick up the baton on that first. Anna, I may look to you for an initial view, but David, Justin, if you do want to come in on that, David, I see you nodding, then I'll go to Hannah, then to David, and Justin, if you want to come in, then please feel free to do so.
Oh, Tim, I think so. What does patient choice mean is a good place to start, doesn't it? So I think patient choice in terms of the elective or episodic requirement still exists. People are offered a choice. But if it's a choice between a long wait or an alternative long wait, or it doesn't necessarily feel like a real option. And I think that's part of the problem with the policy as it stands, is the performance gap is so great as to make it something that somebody feels is meaningful from a politician's perspective to offering to a patient is kind of the lower down the order of concerns right now. I think if we see the NHS's performance improve, it may rise up against, but in the context we've got the lowest satisfaction in the NHS ever, it wouldn't be my vanguard policy if I was in the ministerial team. What I also think is, in the context of what they're saying about general practice and primary care, and in the context of a significantly aging population, how you get coordinated care for people with enduring requirements is now the more material issue for the sustainability of the NHS. Yes, there is a crisis on the waiting list. I personally think it's solvable through using all manner of different providers. And the bigger issue for the country is, how do we deal with the aging population? And patient choice is less relevant in that context, because continuity is a more effective element to how you help people sustain health when there are things that there are issues wrong with them that they're coping with day in, day out.
Great, fantastic, Hannah. David, I saw that you wanted to come in. If there's anything you wanted to add to that.
Yeah, I mean, I think, there is, back to that point, there are no silver bullets in healthcare. It's complex, but choice is a really important component of improving overall service delivery. And we know from research that we've done that if a patient does choose, they can save up to 3.5 months off their waiting time by traveling about half an hour. So, it's a very practical kind of benefit. And I think it's also very empowering as well. I think for too long, there's been a sort of sense of, every time the monthly statistics come out, and that happened again this morning, haven't seen the government reaction to it, but, the government saying, everyone's working really hard to try to improve that. And there's not really a sense of agency about what the individual can do about that, supported by their referring clinician. And I, very much welcome some of the language from the new health secretary who talks about putting patients first. Has been pretty proactive actually about saying the previous government was too slow about bringing back choice-based reforms, and I think it's sort of said publicly as well that he will look at how GPs can be incentivized much more proactively to offer choice, because we know it doesn't happen anywhere near enough. So I think it's definitely part of the overall solution and can bring real benefits.
Great, fantastic. And Justin, was there anything that you'd like to come in at this point?
So 2 quotes from previous Shadow and Labour health secretaries, which sort of emphasise the difference. One quote is, people don't want choice. They just want to be treated quickly by a good provider. And another one is that we want working people to have the same choices as the sharp-elbowed middle classes, both Labour Secretary of State or Shadow. So both points are true, aren't they? Which is, the real thing that people want when they're not well is to get treated. But also, when you are being treated throughout all your pathway, you should be offered choices, not just of provider, but also in your pathway. Even when you have a complex condition, we are talking about patient-centered care, which includes being able to choose the type of treatments that you have. So you have to close the circle on choice if you want, as David said, patients to have agency. Now, in some areas, that really does mean, in our view, having a choice of provider. Because if there are different waiting lists, being able to choose the one which is the shortest or the one which is nearest is highly legitimate, and it does work as a mechanism for bringing waiting lists down. When you get to the more complex end of care, then you start talking about the need for integrated pathways and how you manage choices in those. So just like everything in healthcare, there is not one answer, but having a plurality of providers who also work together has to be the basis of the answer. Whether you're talking independent sector providers and NHS providers, or NHS providers in different locations or with different skills. So I hope choice will be part of it. I would hate to think that you took choice away and patients suddenly became victims of a system that tells you where to go and who to see. That doesn't feel like a 21st century solution. But of course, it has to be integrated, it has to be joined up, and there's a very good commentary in the chat about data. The transportability of data is really key. So Spire, I think, is unique in having access to the NHS patient record for private and NHS patients. That makes the journey smoother and more effective for everybody. So data transfer enables choice. So it's a very key topic.
Right. Fantastic. Thanks, Justin. And I think you brought up a sort of critical point there that, a plurality of providers potentially leads to sort of a more sort of improved health ecosystem for everything and potentially speed through the process. I think it also adds, of course, more complexity into the process as well. More providers means more relationships, means more ways of working. And that's okay. We need to accept that these are the challenges if we want to operate in that kind of system. But I think taking a step, and if we keep thinking about sort of patients being individuals, and of course, an individual has health needs before they even get to the treatment part. And part of that is, diagnosis and understanding they feel unwell, they feel that they have an issue with them, but they don't know what it is. And so the first part of that kind of pathway is obviously getting to primary care or getting to a diagnostics clinic for like imaging. And here we get into a kind of this area where individuals are using their kind of rights as individuals to go and access services which maybe they're entitled to on the NHS, but are struggling to get into because of waiting list demands. And what they are choosing to do is pay out of pocket for certainty rather than waiting, say, sort of 6-12 weeks or longer for a diagnostics, and then another, say, 6-12 weeks or longer for the output potentially of those kind of diagnostics. So that obviously means that people may be accessing treatment diagnostics privately, but potentially looking at the NHS for their treatment. So the question is really about those kind of ways of working. We live in a complex healthcare system. Do you, Justin, I'll perhaps come to you first on this one. Do you think the current ways of working are fit for purpose, given the increasing numbers of people accessing self-pay, potentially PMI diagnostic care? And potentially what do you see as the optimal relationship between the private pay and NHS providers when individuals may increasingly act as customers and potentially shop around for what they feel is the right service for them?
So first of all, I'm sure others will comment on this. There are quite clear rules about this. So if you have a diagnosis of a condition and then you wish to be treated on the NHS, you go back to the NHS, and in the vast majority of cases, you will then go into the NHS system. I'll talk in a second about why I think that is actually challengeable. But I think the rules are pretty clear, and we are very clear about enforcing this. So you don't really get to move ahead if you get a private scan. You will go back. Now, quite inefficiently, our anecdotal experiences, the NHS then says, well, you can't trust that private scanner. They put you on the system, they have to scan all over again, using up precious NHS resource. I suppose philosophically it's a bit more complicated if you get an urgent and critical diagnosis, because I can't imagine the NHS would then say you need to get back on a waiting list, even though we know, for instance, you are likely to have cancer. So my general view is, if people are getting diagnosed, this is a good problem to be dealing with, because people are getting diagnosed, and we're back to focusing on patients. This is a person who has a clear diagnosis that needs treatment. This is a good thing. The fact that they have used their resources to pay for it, in my view, rather than reusing NHS resource, there should be a clear pathway that you can then move up. That might be controversial, but it will also help with waiting lists, because you don't have to go back to the start. By the way, it's interesting to note, if you look at other countries, one of the best health systems in South America is in Chile. And there, this particular issue was resolved by introducing that pathway. And there is a vibrant diagnosis sector, both run by public and private providers, which came up as a consequence and brought down the equivalent to the right-hand side of the slide that Hannah showed, which is the much bigger issue of people getting diagnosis prior to needing inpatient. So I think it needs rethinking about, but I would challenge, not in the context of this is a problem, but this is an opportunity. That's the way I would frame it, if you come back to putting the patient first.
Fantastic, that's excellent. Justin, David, I'll come to you, and then I think we'll move, conscious of time, we'll move on to another question.
Yeah, thanks, Tim. I think it's good to have a debate about diagnostics, because, actually quite a lot of the time when we think about waiting lists, people think about surgery. That is clearly important and needs to be done well. And we've spoken about pathways there. Actually, a big, for many of the people on the list, they're waiting for a diagnosis. And we know as well that quite a lot of people who are just waiting for a routine scan, that will show something up that is very urgent. And we are seeing more of that within the private market as well, of people, having a scan and then, trying to take that back into the NHS. Generally it worked well, but it doesn't always. And I think if you're an individual with that information and knowledge that you have cancer and you need urgent treatment, and there are bureaucratic hurdles for you then to get that treatment between two systems, that just doesn't work for you as a patient. I think we'll probably continue to see more of this. We know that there's a sort of growing number of patients choosing to pay privately for varying things. And I think, frankly, the joins between the two systems, there's work that we could do on that. It's not just on this, but about the interoperability between the two systems, the extent to which patient records can kind of speak across a patient's journey. Because, you know, certainly when we do an annual report called Going Private, which is a sort of extensive consumer insight report into the private market, you know, growing numbers of people are looking positively at private healthcare, and particularly younger people. You know, in the last, you know, when we last did it, previous 12 months, nearly half of 18 to 24-year-olds had used a private GP. It was just 6% of over 65. So we're beginning to see a bit of a change, and I think the system will need to catch up with it.
Great, fantastic. So what I'm going to do is roll a couple of questions into one another. Hannah, I'll come to you first. Answer them as you any part of them as you see fit, and I'll come to David and Justin as well for any other views. So I think the big one is we have a new Labour government. They have the ability to introduce regulatory changes, legislative changes, financial kind of changes. They've got a 170 plus majority. If they want to, they can push through most of what they would like to push through. So I think one question, perhaps people who perhaps aren't so close to the legislative process, Hannah, you may be able to sort of speak to this. David, you may be able to speak to this, certainly. How, if they begin to introduce kind of policies and legislation and regulation, like you imagine they introduce them in their kind of year one, which is unlikely, how long in reality should the private sector providers think that that's going to take to come into actual practical effect? Would it be 1 year, 2 years, 3 years, 4 years? I mean, obviously it might depend on the change, but just one of the sort of questions that we had in the group. And then alongside that, perhaps to sort of frame it a bit more, there's been questions around, do you expect sort of kind of regulatory changes in the quality environment, the ability for the independent sector to kind of better be able to negotiate NHS tariffs, tariff payments, and then also about whether kind of there'll be changes to NHS run private patient units. That's 3 areas which, you know, a government could put some kind of options into. So Hannah, picking any one or all of those, do you have any initial reflections?
Goodness, that was a broad question, Tim. I think the thing to remember is government has significant flexibility in the policy landscape, and the legislation that does exist, other than the structures that it sets out within it, is relatively permissive. And so if they make core policy decisions, you can, and I think we can see this already in what they're saying. You can see them driving to want to enact that relatively quickly. I think they are doing some things that are measured, like asking Lord Darcy to kind of review the performance of the NHS. So there's like various kind of assessment things, I think, that are going on in one form or another to stand back and think and make sure that they're clear before they act. But on a decision, I mean, it's like weeks that you could begin to affect change. Is how quickly can the delivery chain in the system, and how quickly can you change people's behaviors? And that really is like the adoption issue. Some people will do it very fast and some people will do it slowly. If they want to do something that requires legislative change, which because it's much more cumbersome and it takes longer, I think it's like a fallback. So if they are frustrated by their inability to reform, which is one of the words that's in the chat, which I think is they have a reforming agenda. If they're frustrated by pace, change, the NHS's ability to enact it, that's when we might see legislative change. And those things take time, because just the process of getting a bill through Parliament takes time, and then enacting it takes time. So that's more like 1 to 2 years, which is why it's a bit of a last resort, in my view, to do it. Let's see how much they can do within the existing instruments.
Absolutely. So soft policy levers where possible, not hard legislative kind of. Okay, fantastic. David, obviously you're talking to sort of the government and various people in DHSC on a very regular basis. What, based on those kinds of questions, regulatory change, maybe changes to PPUs, changes to the sort of funding tariff, and how the independent sector can kind of interact with that? obviously you don't have, you can't sort of say for sure, but anything which you can kind of sort of reflect on as you feel there may be a direction of travel, maybe the Labour government might be interested in.
So yeah, a lot there. I mean, on PPUs, I mean, no sort of sense we're in sort of late 1970s Barbara Castle era of banning private pay beds within the NHS, and I think an acceptance actually that the income that generates can be quite helpful. I know that's sort of not universal across the country, but nevertheless, I think is not picking up anything that will dramatically change there. I think there is an acceptance that the tariff system, and particularly the way that the price is set, has been allowed to atrophy over recent years. We obviously had the pandemic, and then at least a couple of years where the NHS was on block contracts for a lot of work. It's now back onto payment by results, but I don't think the costing data has been updated for several years. And that does provide a threat to any provider of services when actually cost and price are out of alignment. And clearly the NHS sets the price. That's quite, that's their prerogative, but it needs to be done in a way that is accurate and uses kind of accurate costing information. On regulation, I think someone was saying to me the other day there's 129 regulators in healthcare, and they've been sort of added to quite extensively in recent years. Potential opportunity just to kind of have a look at that. We're very supportive as an industry of the safety and quality regulators, particularly the CQC. It's critical that that's working right, and that that patients can understand the good and potentially the bad of any provider, and that also should help them to make their decisions. And I think it's great that is a single system across both NHS and private. Other regulations, I suspect, as Hannah says, will probably, other than those in the manifesto, will wait to see whether or not you can achieve change without needing to resort to regulation or new legislation.
Fantastic, David. And we're getting very close to time, so I'm going to ask Justin one very last question, and before I sort of wrap things up. And one of the questions in the chat is around, and you can speak to this from a kind of sector perspective or a Spire perspective, it's entirely up to you how you want to take it, is how you sort of go about balancing responding to the waiting loss opportunity. As you said at the top, you do have spare capacity, which isn't always taken up, with swapping margin for volume. So it's effectively, as a private acute provider, how are you thinking about maintaining that blend between public and private pay from a revenue stream perspective, given that there may still be demand in the self-pay and the PMI market, which would allow you to shift away potentially from NHS-funded care options, thereby potentially undermining the Labour objectives. Anything you'd like to speak to from a Spire or a sector perspective on that?
I'll respond to that, and also a couple of, I think, points to add in right at the end on the other question. So the answer is, that's our day job, and that won't get in the way of supporting a new government help with waiting list initiatives. I can tell you, for instance, that Sundays are very quiet at Spire Healthcare. So we've got plenty of ability to do all of the above. We are busy, but of course we can be busier. So really the challenge is, how do you just manage with getting busier? Now there's two sub-things. A question in the chat about workforce. We should close. Workforce is key. None of this will happen without an engaged workforce. We're very interested by the New Deal for working people, because workplace health is key. And it's something we lean into with occupational health and mental health provision. And long term, we've got to make people healthier so they don't end up on a waiting list. So there's a whole nother interesting discussion there. And we have been very successful with apprenticeships, so we don't have a shortage of nurses. So I think there's a whole nother thing that Labour could do without legislation, which should really lean into helping people who might not normally become healthcare professionals be so. So I'm in the world of and not all, and there's lots of other exciting things which can be done going forward.
Fantastic, Justin. Thank you so much. And an answer which has kept us almost exactly to time. So thank you so much. We're going to wrap things up now. First of all, I'd just like to say a big thank you to our panelists who have joined us today. Just to introduce them one final time: Hannah Farrar of Carnall Farrar, David Hare of the Independent Healthcare Providers Network, and Justin Ash of Spire Healthcare Group. Thank you so much for joining us and for giving your perspectives on the questions. For those who are still on the line, just a kind of quick look at what's coming up for LaingBuisson in autumn. We all think that the private healthcare space is an incredibly interesting one to be in, and the Labour views are positive for the sector. We will be publishing we have our private healthcare self-pay report, which came out in June, out now with data up till, I believe, April 2024. We're launching a new product called Health Search in September 2024. And of course, we have the Private Acute Healthcare Conference on Wednesday, the 9th of October. So we hope that we'll see plenty of you at that. But that's it from me. That's it from LaingBuisson. And thanks again to all of our panelists.